This week on the BackTable Podcast.
I will tell you, for better or for worse, I kind of present the other options maybe a little bit more generously, if that's a a reasonable way to say it. And as we know, it depends on the patient, depends on what's going on. There's a lot of factors involved. You can kind of see it in their eyes, right? When you tell them that your bladder's coming out, and you an older patient, you need an ostomy bag. You can see it in the family's eyes, you can see it in their eyes, and you say, well, there are other options. There are higher risk of relapse, higher risk of progression with some of these other options, but this is something that could be worth a try.
This is Aditya Bagrodia as your host this week, and I'm excited to introduce our guest today, Tom Jayram, who's joining us from Nashville, Tennessee. Tom, how's it going today?
Hey, how are you? Thanks for having me.
I'm good. Such a small world. It turns out that Tom is in the same group as two of my co-chiefs and dear friends, Danny Ramirez and Jim Belsante. Go figure.
Yeah.
And as we kind of jump into it, Tom, of course, we'll talk about bladder cancer. If you don't mind, just tell me a little bit about, your quick urologic story, how you wound up in Nashville, a little bit about your practice, if you don't mind.
Yeah, so, it's like half a degree of separation within your, amongst urologists. But I'm from Chicago, the suburbs of Chicago. I did my medical school here at Vanderbilt and really liked Nashville and made a lot of friends here. Then I did my residency at University of Chicago. And so, got a good oncology background there. And then did a fellowship at Hopkins with Mo Alof and Trinity Bevilacqua and those guys. And there was a strong emphasis on, kind of MIS and oncology when I was there. And then I decided to come back into private practice down here in a big LUGPA group, about 30 urologists, about 14 or 15 mid-level providers. So a big group that, really has a lot of different kind of subspecialty angles. As you mentioned, your two colleagues are kind of in the same boat. We joke around that we're all general urologists to some degree, but in the community and now in big groups, you can really subspecialize pretty well because of just how many doctors that are around. So I've been fortunate. I've been in the group now 12 years, busy urologic oncologist, bladder, kidney, prostate cancer. I've taken a special kind of interest in bladder cancer. I don't know why. Sometimes I think that was, when I come home late at nights, I ask myself why, but it's, as you know, bladder cancer is a complicated disease. And in the community, there are a lot of areas for improvement. There's a lot of gaps in how we treat bladder cancer. And so it's kind of been a passion project of mine over the last several years. And I've been fortunate to work with LUGPA and work with other big organizations, Beacon, to really try to move forward the care of bladder cancer in the community to try and address some of the gaps that we have. So that's kind of, my story. I'm also fortunate to really be involved in clinical trials. I direct one of the biggest clinical trials programs from a community standpoint in the country. We have 15 to 18 active trials. And so, a big part of what I do is research, and it's really worked out well, and it's been really rewarding.
Yeah, that's amazing, Tom. Thanks for sharing that. And, if I take like a quick, non-scripted reflection back on the last 12 years, I think we're roughly the same vintage. Some of the things that have come through that are noteworthy in bladder cancer, just again, off the top of my head, maybe larger incorporation of robotic cystectomy, the constant ebb and flow of BCG shortages, managing with that. I think base standard of care, that's something you're probably going to see from referring doctors kind of outside of Nashville proper, so to speak. Then the explosion of activity in the BCG unresponsive state, blue light cystoscopy, maybe I'll throw that out there, as some technologies. And I guess it's kind of incumbent on us as academic urologists to kind of keep it up and expose the residents to it, et cetera. Can you maybe just talk about, when new technologies are kind of coming through or new ideas, approaches, how you as a group or you as an individual say, I want to do it, I don't want to do it, I think it's worthwhile, it seems challenging, the capital equipment requests are nutty. How does that all work in your real life?
It's a great question. And it's been, like I said, part of this whole movement within big community practice to try and improve cancer care. There's just fundamental differences, right, between hospital-based organizations and groups like mine. So completely independent group. We're not affiliated with a hospital. We're, thankfully, we are still independent, amongst all this integration that's going on in urology. We're completely independent. So to your point, we have various structures and we have committees, the governing board, but ultimately, if there's a new technology that's interesting and that moves the needle for our patients, there's usually a champion physician that kind of brings it to a higher level, and then we talk about it. But one of the bigger differences is we do focus on the finances, the economics. It has to at least be a net neutral for us. Otherwise, it's very difficult to sustain. And so it's one of these things that in the bigger picture of this, and this is one thing that I've been kind of preaching for a while, a lot of my partners are tired of hearing me say this, is we can't look at the line item, every single thing that we do, if it makes money or not. And obviously that's not the right way to do it. As we're seeing such an explosion, like you said, of cancer care, diagnostics, treatments, imaging, all things that are coming, what we have to realize is that sometimes you're going to have to bring something in that may not be very cost effective, but it's going to enhance everything else, right? It's going to be indirect revenue, indirect profit, improvement in patient care, and that is going to drive downstream visibility of your program and visibility of the overall service line. So, yeah, I mean, we have kind of a P&T committee or whatever that people come to and say, hey, this is what I'm interested in bringing in. And then we talk a little bit about the finances, but there are some things that unfortunately just will never be able to move the needle. Blue light cystoscopy is a very interesting example. In the community, blue light cystoscopy, it's obviously extremely valuable. I've been a champion of blue light cystoscopy for a long time. We own our own surgery center. It's kind of attached to our main building, but there is no code, as you know, there's no different reimbursement code for doing blue light cystoscopy or doing a TURBT blue light. So what that means is you're making the same amount of revenue that you would if you didn't have the technology. And the technology is quite expensive, right? There is a tower, a special set of scopes, and then you have to buy and bill for the actual agent, which you put in the bladder. So the finances of that, if there's no increased compensation or reimbursement, are very difficult. And it's not that we say, well, we're not going to do it. We just say, well, let's work with the hospital, right? And so that's kind of how we do it. We've been doing flexible blue light in the office, which has been really great, but very recently there have been some now new challenges to that as well, because there's the scope support for flexible scopes has become more difficult. So I would say it's an interesting lesson for a lot of younger urologists who are, kind of thinking about things and how to get things done. And it's a little bit difficult. It's a little bit more complicated to just bring stuff in big community practice. Doesn't mean it doesn't happen. And like I said, there's things that we lose money on all the time, right? MRI is the perfect example. MRI fusion biopsies for a long time, right? You don't get anything more for doing an MRI fusion biopsy. It's the same thing as doing a regular biopsy, but we all realize that it's better for our patients. And there's a lot of clinical improvement that we see in prostate cancer from it. So we've adopted it, but we have to be careful in the community because, again, we have to keep the lights on, number one. Number two, we have to be cost effective, and we have to try to promote value in what we're doing. And just buying all of the latest, greatest new gadgets sometimes doesn't work.
Yeah, well, this topic's fascinating to me, and it's MRI is just, and I'm going to stop talking about this because I do find it to be fascinating. If you become less familiar with MRIs and you don't do MRI fusion biopsies, you're already kind of one step, in my opinion, kind of starting to get behind the eight ball.
Right.
And then like new things come in. You'd mentioned Danny Ramirez, awesome guy doing a gazillion transperineal biopsies. Now you add in like a whole new technology, a whole new approach, and it seems like you get one step removed. The next thing you wake up one day, you're like, oh my God, what the heck? I'm practicing a relatively obsolete brand of medicine.
Yeah, absolutely.
And, while I started off by saying there have been these major advancements in bladder cancer care, one could easily say that those are incremental, generally speaking. Robotic cystectomy, this is not like life and death. Blue light, this is not like life and death. ERAS pathways, this is not life and death. But it is probably overall, improving the standard of care. And I guess what I would, coming back to bladder cancer, advanced non-metastatic bladder cancer, as a huge group in Nashville, do you feel like picking and choosing your battles, having clinical trials available, offering some things that may be a little bit unavailable in your surrounding has allowed you to continue to grow and take the best care of patients in Tennessee? And specifically, maybe you can talk about referrals. Like, are you seeing a lot of new patients with complicated bladder cancer?
Yeah, it's a great question. So I would say that now what's happening, we kind of hinted at this before, is in big groups, you have these champions in certain disease states. And so, I'm kind of the champion for bladder cancer in our group. And so what we've done is we've implemented a few small things that I think have been very impactful to improve the quality, the average quality of care that's given in our group for bladder cancer. So for example, there's a BCG log, right? So any patient that is being requested to get BCG, I review the log and we basically go from there. And that may sound something super silly, but you've got to realize in a group of 30 doctors, a lot of doctors, especially in the community who are maybe a little bit older, they don't go to meetings. They don't necessarily see all the new stuff that's going on. Things are happening a mile a minute. And so it's important to understand how they're using BCG, what the limitations are in our group, what we can do better. And so just a simple thing like that has really improved, our bladder cancer program. And during the shortage, it was huge, right? It really helped us figure out what was happening. So, are we giving BCG for low-risk disease? Are we giving unnecessary surveillance? Are we giving unnecessary induction, reinduction treatments when people clearly are not responsive to BCG? And so things like that have been really helpful. So, yeah, I think the short answer to your question is by putting all of these things in clinical trials, access to advanced imaging and genomics, and prostate has definitely taken the lead on a lot of that stuff. But as you know, it's coming to bladder. And by kind of saying, okay, well, here, I'm here as a champion physician. If you guys need anything or if you have a complicated case or whatnot, feel free to refer. And what you found is a lot of people are just referring it because as you said, it's getting very complicated. People don't know we have LUGPA survey data of, what percentage of urologists know the definition of BCG unresponsive disease. And as you can imagine, it's pretty low. And I would probably say even in academics, if you're not in bladder cancer, you probably don't have a great idea of that definition, right? It's a pretty complicated definition. So I think that what we've seen is a lot of people are referred over and then, running 6, 7, 9, 10 clinical trials in bladder cancer, I can pick some of these patients off and say, hey, this would be a good patient for your trial. This would be a good patient, maybe for an alternate therapy, an advanced therapy, things like Adstiladrin, things like gemcitabine-doxorubicin. Again, in the community, these are not super easy to give. You have to operationalize around each of these things. And so it's hard for the average urologist who doesn't do much bladder cancer to just say, I think I want to give this patient Adstiladrin. They're going to have 30 questions about it and how to do it and whatnot. And so you may as well just refer it. So we've kind of created these touch points, not just in bladder cancer, but in other cancers as well, other disease states as well, where you just refer into the champion and let the champion take care of it. But the other nice thing is if you do it well and if you do it efficiently, as you know, that comes with gain for the practice. So that's kind of been the model that we've had. There's really nothing that we don't do. 20 or 30 years ago, a lot of private doctors were not doing radical cystectomies. Now, most big LUGPA groups have 1 or 2 doctors that are doing a lot of cystectomies. And the reason is as you said, they're getting better at it. The ERAS pathways and the robotic component are, patients, their outcomes are better. And so it's not as big of a lift as it was when you say, oh, well, it's a huge operation, 90-day global, 50% readmission rate, et cetera, et cetera. Now it's not as daunting to do those operations. And we're getting a lot of really talented people coming out of fellowship into these big groups. And so we're starting to see that all of these things are now being packaged into the bladder cancer kind of program.
Yeah, that's amazing. And just a couple of comments. I mean, we have a BCG inventory as well, and we've got our policies where, if you're not on trial, you're basically getting half dose induction and maintenance is going to be gemcitabine-doxorubicin monthly, for instance. And, we got to do it. And that's the first comment. The second thing is I find more of my colleagues, even within the practice, within our academic practice, if they see a bladder cancer, maybe 5-10 years ago, it's like, I'll do the TRBT and send them on, but more, let's get them on over there out of the gates because there are trials, there's some nuances, there's some technologies. And the third thing is, one of the things that seems to be a very positive evolution in my mind is a relationship between practice, industry, and academics. Obviously you're in Nashville with Vandy right there. And I'd love to think, and talking to Sam and Dave and Jim and Danny, it sounds like everybody plays really, really nice in the sandbox and it all kind of works. So I think these are for access, et cetera. We really just want as many people that are doing a good job taking care of patients, given the shortages and so forth. So those are just a couple of comments that I had on what you just said there, Tom. Very insightful. So, all right. So you're seeing a lot of bladder cancer patients, and maybe we could start out with the folks that you're diagnosing and then the folks that are coming in as referrals to you. And we'll restrict our conversation to high-grade, high-risk disease, just to kind of keep it digestible. So folks that are coming in to see you, microscopic hematuria, gross hematuria, are these usually just direct referrals to you, or how does that kind of work?
Yeah, so two kind of pots of referrals. It's intragroup referrals. So, people who have seen one of our providers, again, 40 plus providers, doctors plus APPs around Middle Tennessee, probably have an area of about 60-mile radius where we've covered, Middle Tennessee, maybe 40 miles, something like that. So there are a lot of patients that come in through the group, see somebody else. And, for the most part, I think that urologists are good at managing bladder cancer. They utilize the NCCN guidelines. They risk stratify people. We could always do a better job. That's something that I've kind of preached a little bit to the group is, risk stratification, all the stuff we talk about for quality metrics, repeat TURBT, all that stuff. And so if, and then we haven't really been crushed by the BCG shortage. We've been tinkered with here or there. Big groups, as it's historical allocation. So big groups tend to have have a pretty stable supply. So they usually put a request in for BCG at that spot. As you know, there's a lot of stuff going on in BCG naive for clinical trials. And so one thing that I usually do still is look and see if there's an appetite for patients who maybe have another doctor to say, hey, do they want to come in and talk about a trial, right? Some of the younger, healthier patients who maybe have high-grade T1, we've been offering them our intensification trials where they're getting IO agent plus BCG. And there's a lot of excitement about those trials reading out. A lot of them are going to read out actually within 12 months. So that'll be really interesting. And then, so they either get referred in, through a partner but they usually don't come in until they're BCG unresponsive or at least BCG exposed to see if we have a trial or if we would do something different. And then the other pot is kind of outside urologists. So a lot of the rural and the peripheral urologists. One of the things that I've worked hard to do is kind of build some good relationships with some of the doctors out in the periphery, right? Southern Kentucky, Northern Alabama, West Tennessee. A lot of those urologists obviously, don't do cystectomies. They're not that compelled. They don't have access to gemcitabine-doxorubicin. They don't have access to some of these more complicated treatments. So that's another nice referral base where they send in some of the more complicated patients in and we try to help patients through.
Okay. So maybe we'll start with your practice. They're coming in, they've had hematuria, got a CT scan. You may or may not have scoped them in the clinic. What's your general practice, just out of curiosity?
If I'm seeing a new patient with gross hematuria?
Yeah, and say a CT scan shows a mass in the bladder. Is that a clinic cysto, or do you typically just save that for the OR?
Yeah, if the CT shows something, I'm usually putting them on. I'm usually talking to them. Now, if there's a complicating factor, if they're on Eliquis, if they've had a bunch of stents, if they're a high anesthetic risk, maybe we'll send a cytology and then do a clinic cysto, right? If it's low grade, you might be able to get away with not needing to put them to sleep completely. As you know, you always like to have that initial diagnosis under anesthesia where you can do a good TUR. But yeah, I would say most of the time I prefer to go to the OR.
Perfect. So OR, do you all have residents rotate through, just out of curiosity?
We did. Next time you talk to Sam or Dave, ask them where they went. No, we used to, for a long time, the Vandy residents used to do their private practice rotation with us, which was, just a 4-month block when they were a PGY for work. But Vandy's expanded a lot. They've got a lot of sites. So they as of now, they've pulled the resident, but hopefully we can re-engage at some point.
Okay. So when you're doing your TURBTs, are those typically done with blue light enhancement for the first go around, or do you feel strongly?
So short answer is it depends. Usually I would say about half of them, no. We just take them to our surgery center and we just do it under white light. And then based on what I see, then I'll inform my notes and myself to maybe say, okay, if they have a lot of CIS or if they have disease that's, somewhat challenging to see, then maybe we can do it in blue light in the hospital down the road. There are a group of patients who have the state insurance, Blue Cross state insurance, that can only be taken to one of our hospitals that have blue light. So that's a no-brainer. So we just use blue light all the time then. And then there are a group of patients who have HCA insurance, so they can only go to one hospital and they don't have blue light. Again, we talk about the real world. This is kind of the real world, is that a lot of the insurance does guide what we do, but we have access to blue light. So if there's someone who I really think would benefit from blue light, we do it. In the naive situation where I've never scoped them before, I usually don't do that right away.
It's kind of like sometimes when you just sit down with people, the real world and maybe the academic non-real world are quite similar. We don't have towers at every hospital that we go to. It's just doesn't make any sense financially, and shipping those towers and equipment around also wouldn't be very effective. So you mentioned your documentation and so forth. What are the kind of critical bits that go in there? So when you're sitting down with the patient in the clinic and looking at the pathology, trying to put it all together, you can help tell Mr. or Mrs. volunteer.
And I think this is really important, because when you have a high volume bladder cancer practice, as you know, things start to run together a little bit. It's easy. And, unless you're really on top of it, I think it's easy to produce somewhat generic notes and documentation. And, just for example, on a Tuesday, which is my, all day clinic day, where I'm doing all the office cystos for surveillance and whatnot, I'm usually doing 10, 8 to 10 office cystos a day interspersed between, 40 clinic patients. So you have to find your own, everyone's got their own way of doing it, but you have to find a way to document well. So, I would say location of tumor, where the size of the tumor, I always note, previous treatment. This patient has not, the patient has not had any prior intravesical therapy, because as odd things in the bladder are common after you've had intravesical therapy. So, location of tumor, size of tumor, number of tumors, access to the tumor. Is the tumor in an area that, may be difficult to access? And then, obviously related findings about, how the bladder looks in general, the urethra, all of that stuff. But that is something that I think we talked about, some of these gaps in the community, right? How surgeons document their cystos and their TURBTs is poor. And there's no doubt about it. We all could be better in doing that. It can sometimes make a big clinical impact. If, I get a lot of outside TUR reports that I'm looking at, and it says patient had a tumor on the left lateral wall, it was resected, there was no visible tumor left. That's it. And then you get a lot, you get some really good.
Well, then you look in there and it's like nothing ever took place, right? I mean, especially.
And you don't know what happened. You don't know how big was the tumor to start with. Where was it? And then you see 4 or 5, other areas, and you're wondering, well, are these new? And, did these just pop up? So the documentation is really important. And so, you have to have kind of a way to look into a bladder in both an office situation and in an OR situation, and really try to describe, what you see. I think that one thing that's important too is, we talk a little bit about CIS, carcinoma in situ is a really this driving space now for a lot of these new therapies and clinical trials. As someone who runs a lot of clinical trials, what's interesting is, the RECIST criteria for solid tumors, right? That's what a lot of clinical trials go by, where you measure tumors on a scan, on a cross-sectional scan, and you say, okay, well, the tumor was 2.5 centimeters 3 months ago, now it's 1.9 centimeters. So that's a partial response, right? Or it's gone, it's a complete response. We don't have that ability cystoscopically, and with these trials, and I'm sure you've heard this point before, these trials are kind of designed not really mirroring what we do in the real world. If someone has a bladder full of CIS and you put BCG in their bladder and their bladders still have maybe a little patch, but most of the CIS is gone, you wouldn't consider that patient a failure, right? You'd actually say, hey, this patient's doing great. But guess what? Most of the trials, that patient gets kicked out as a failure. And so it doesn't really mirror what we're doing in the real world. And now some of these newer trials are using reinduction and they're doing a second course, but some of the older trials did not. And so their numbers, right, their CR numbers are going to be different. And so I always tell people, you can't just look at CR numbers, and compare these trials across board. So that gets to my point of being able to document well. And if you see a patch of CIS, how big is it? How much of the bladder is involved? Because when you follow that patient up, and if you see an area that's still abnormal, well, is it smaller? Because if it's smaller, I would argue you don't need to completely toss that patient or completely move away from that treatment. Obviously, there are other clinical factors that you would have to think about. But, my personal belief is as we get into this world, there's therapies are going to start sequencing together, right? You're not just going to say, okay, well, you still have CIS in your bladder, we're going to take your bladder out. You're going to look to other therapies and look to kind of really do everything you can to keep patients' bladders in their bodies.
Yeah, and between that and the pathology, which we'll talk about, anytime I'm seeing a patient with non-muscle invasive bladder cancer, the main question I'm asking myself, am I going to potentially miss an opportunity of a window for cure if I try something intravesical? Now, if that's BCG naive and they've got multifocal, nodular, extensive CIS, 50% of their bladder wall, variant histology, that person's going to get a fairly straightforward recommendation from me, at least as the standard of care is your bladder's got to come out, sir or ma'am, to not have you die of bladder cancer. And one of the things that I think makes me a little bit nervous, especially as we get more tools in our toolkit, is trying to sort out who that patient it is at any given time point. We're making this decision on if it worked perfectly, all right, that's a no-brainer. If it worked 90%, like you're saying, extensive CIS, and I get a small little patch, you're not worried that person's going to med out in the next 3 months. But it's that gray, right, where you're like, this doesn't feel good, it doesn't feel awful, and nothing fits into nice little tidy boxes. The trials that are all CIS only or with or without papillary. Well, how do you factor in if their bladder looked like choose your expletive? That's the real world, right? And so, yeah, I think there's lots and lots and lots in the TUR, in the office cysto, and in the path. And maybe I'll just start out with this. My red flags are going to be widely invasive laminar propria invasion, lymphovascular invasion, variant histologies. Those are where my alarms are going off, oh boy, we got kind of a problem here.
Totally agree with you. And I always start the conversation with a radical cystectomy is going to be the best thing I could do for you right now to prevent you from dying of bladder cancer. However, in the community, and this is, I think, an interesting community phenomenon, if I say you need a cystectomy, there's a decent chance that, and not all patients are different, there's a decent chance a patient's going to get another opinion. And the ability for me is, that message coming from an academic center, I think is better received because the academic side is usually the end, right? The end of the journey. And so I will tell you, for better or for worse, I kind of, I always start with that discussion, but I think I present the other options maybe a little bit more generously, if that's a reasonable way to say it, because, and as we know, it depends on the patient, depends on what's going on. There's a lot of factors involved. You can kind of see it in their eyes, right? When you tell them that your bladder's coming out, and you an older patient, you need an ostomy bag. You can see in the family's eyes, you can see in their eyes, and you can say, well, there are other options. They're likely, there are higher risk of relapse, higher risk of progression with some of these other options, but this is something that could be worth a try. And I think the cool thing about this era of all these new treatments is it's going to test a lot of that. We're going to start to get a lot of data on how many of these patients are actually progressing, how many of these patients are holding on to their bladders, right? Adstiladrin had some good data that they published about 5-year data that even though they had patients who recurred, a really high percentage of patients still had their bladder within 5 years after they started that trial. So while you may recur, my feeling is that if you select your patients well and you're doing this, you're diligent about how you're treating patients, my feeling is that you're not letting a lot of patients progress. So I think recurrence is going to be somewhat common. Hopefully we pick off progression and we pick off those patients earlier. But as you mentioned, we don't know who those patients are. ctDNA may help down the road. Genomics may help down the road. MRI staging may help a little bit down the road. But I agree with you. But for pure CIS, there's data now that 5-year rates of progression to muscle invasive disease are actually pretty low, right? 20 to 30%. So I'm of the camp, and I definitely know people will argue with me, and I'm happy for people to throw tomatoes at me here. But I think that if it's CIS alone and there's a quantitative improvement on therapy, that we should keep trying to find bladder-sparing options. Obviously, it's a discussion with the patient. You talk about the risks, but that's kind of my impression.
No, and I totally hear you. When I came out of residency and fellowship, anybody with muscle-invasive bladder cancer, the only options were neoadjuvant chemotherapy followed by cystectomy. That was it. There was no, let's get rid of the neoadjuvant, let's pickle them until they're a shell of the person they used to be, and then take out their bladders, chemo radiation. That's not really something that was kind of prime time. And, now we all live in the real world. And, I just had a wonderful conversation with Ashish Kamat, and he's like, we don't give everybody neoadjuvant chemo. Well, yeah, it makes sense, right? If they're old and they're sick and they're frail, or if you're hard to quantify, not worried, you're kind of taking all of that into it. So I hear you. And I think it kicked off with, you at least have to mention it. I think that's where, when patients are, I wouldn't say falsely misled, but maybe not just given the gravity of their disease. And obviously, non-muscle invasive bladder cancer is a huge heterogeneous disease state, right? And T1 high grade nasty player versus small solitary TA high grade. Those are different. So I appreciate that. And maybe let's just kind of bang through. So new high-grade bladder cancer, is that person, unless they're getting an intensified trial or maybe bridge trial, we have that open here, are they getting BCG, typically speaking, in your practice if you've got the stocks and so forth?
Yeah, most all of them are getting BCG for induction, and then I usually scope them. And so, this is another thing, obviously dealer's choice. A lot of people are different. If they're higher risk, if they had high-grade T1 to begin with, or high-grade or a lot of CIS, I usually do that surveillance in the OR, that first surveillance with 6 weeks. And I'm a big fan of doing biopsies with them awake. It makes me feel better. It makes the patient feel better to document that they didn't have active cancer in their bladder, right? So I'm a big fan of doing that. And then for all of my higher-risk patients, we usually advise maintenance, definitely for a year. And then it just depends on supply. If supply is not an issue and, we're not struggling with a bunch of new patients with new diagnoses that month, then usually we keep going. I've got a couple guys in their 30s or 40s who I really would love for them to get to 3 years, because obviously the data is really strong for getting them to 3 years of maintenance. But honestly, the typical 60 to 70-year-old patient, as you know, they don't love BCG. They don't finish it in a really quick period of time. And so 1 year of maintenance, I think, if their bladder looks clean, we usually stop there. And then some of my kind of, like you said, the high-grade TA that's a small lesion, they maybe even fit in the intermediate risk category. I usually do induction, and then if their bladder looks clean, sometimes we watch.
Yeah, and it brings up a point that whenever we're talking about bladder-sparing approaches, you got to have a bladder worth sparing. If they're miserable and they're, knocked out for 2 weeks after every BCG installation, and many times they're just like, take it out, doc. I'm ready to sleep through the night and kind of get on with it. Okay, so first cysto, whether in the office or in the OR, CIS only. How does that conversation look like?
Yeah, so if they've had BCG times 6 and they have, CIS only, Again, it depends on where they started, right? Where were we when we started? If they had high-grade TA and it was a small area, and now they have a bigger area of CIS, it's a little bit more concerning, but technically still, again, doesn't really meet the criteria for BCG unresponsive. And so I generally will reinduce that person. Now, if they have a really, if they have a ton of CIS, they're really young, we'll start talking about cystectomy. And like you said, a lot of it is just planting the notions in the patients in their head, right, about what to expect. So you don't want them to fail again and then say, we need to take your bladder out. And then they're like, well, when was this even part of the discussion? So we'll talk about everything. And that also might be a good person where, we use blue light on follow-up surveillance, but I usually do a reinduction course of BCG.
And are you all able to give them full dose induction?
Yeah.
Okay, great. So I think that's pretty consistent. If it's extensive, progressive, alarm bells, we should really talk about a cystectomy. And if they're unwilling or unfit, we can talk about some other options. If they progress with more CIS, I think that's basically BCG unresponsive disease. It's not the FDA definition, which was intended for FDA approval, but clinically it's like, yeah, this patient is not responding, and I don't think they're going to benefit from another course of BCG. I also, it's so easy to forget when we're talking about non-muscle invasive, restaging. I get top to bottom CT scans just to make sure there's, no kind of weird stuff going on. Okay. What about if they've got papillary disease after induction?
Yeah. So obviously important to do a good, adequate TUR, make sure you know that what their muscle invasion status is. And again, if their high-grade TA still doesn't meet the criteria for BCG unresponsive, so I would lean more towards a reinduction course. Multifocal, bigger areas, again, the discussion also about a cystectomy, but I would lean towards another course of BCG. If they're high-grade T1, then you have to have a real discussion with that group because, as you know, now you start to have this, they would likely they qualify for, this kind of BCG unresponsive phenotype. And I think it just depends on a lot of things: age, preferences, how they've tolerated initial intravesical therapy. I re-resect them, maximally, and if I feel good about the resection and I don't feel like, there's a tremendous amount of disease, I think gemdosi is a reasonable option. We have some BCG exposed trials as well. And I've had some patients who have said, hey, can we just give it another shot with 6 more BCG? Now, obviously, like we've talked about, a lot of it is how you counsel them, how you discuss it with them. I really haven't pulled the trigger in the last couple of years on doing a cystectomy in this group at that stage, unless I had a patient who had high-grade T1 with micropapillary features. Yeah, that patient got a cystectomy. But I've had several with high-grade T1 that I've resected well, and then either moved them to a clinical trial or moved them to further intravesical therapy, and they've done okay. I think the bridge trial will be interesting. Gemdosi has a lot of great data in this space, and so I guess my first inclination will be to move them to Gemdosi. But I've had a couple people who have just gotten another round of BCG, and they've done okay as well.
Okay, and I appreciate it. This is intended to be practical. I don't think anything you're saying is like, oh my gosh, this is, you got to meet the patient where they're at, and you're using some of your clinical assessment of the whole scenario, the taking into sociodemographics, the travel, the tolerance of the BCG, the lower urinary tract symptoms. I mean, it's a whole gamish, right? And we're trying to make a decision on how to best manage these folks. And, for the CIS and for the TA high grades that are smaller, if they've got a little small 1 centimeter TA high grade after having extensive T1 high grade, again, I don't think we're going to call that a rip-roaring failure. So it sounds like, and it's funny, right? I'm the one who says you can't put things in neat, tidy buckets. But let's just say that you're the not worried bucket, but there's tumor. Maybe you're thinking a repeat induction course of BCG. The I'm worried course is more like cystectomy should really be our top line option from a cancer perspective. Then there's the boatloads of gray. And maybe, so you mentioned gemdosi. Sounds like that's your kind of typical next option if BCG didn't work. Makes a lot of sense. A little bit trickier to give, talking about practical considerations, a couple hours, a little bit more nursing support, so on. But maybe when you're thinking about even bringing them into the clinic, so I'll throw this out there. When I think about this disease state comprehensively, you've got cystectomy, you've got Pembro, you've got off-label gemdosi, you've got Adstiladrin, you got IL-15 superagonist, Activa, and we've got a couple coming through the pike that are going to be FDA approved likely within the next 4 to 6 months. Valrubicin, which I don't think anybody uses anymore, mostly of historical interest only. And then clinical trials, of course. Did I miss anything? Does it sound about okay?
Yeah, so now you're talking about BCG unresponsive with CIS. Yeah.
Yeah.
And what's interesting is, yeah, absolutely. That's pretty much the menu. And, if you have papillary-only disease, you can still get some of these things approved, right? Because they are Category 2B recommendations in the NCCN guidelines. But we really don't, it's still technically off-label, and we don't have, and that matters in my world quite a bit, because as I'm sure we'll get to, the cost of a lot of these drugs is exorbitant, right? So what we can't do in community groups like mine is buy and bill for this huge, expensive drug and then have even an inkling that it may not get reimbursed. So we are not going to go rogue and order something unless we have absolute certainty from a pre-auth specialist here that we're going to get it approved. And that's less likely if we're doing it off-label. So, but I know at academic centers, it's a little bit easier to do some of that stuff. And that it'll come with due time. And there's already been a lot of strides made for some of these expensive buy and bills in terms of getting ASP. And, there's this whole world that I have to deal with, about Medicare pass-through status and Medicare versus Medicare Advantage, all of this stuff. It's terribly boring and annoying, but it has a huge impact on patients. So once they get to be BCG unresponsive, and presumably, the high-grade T1 guy who had 6 of BCG, you can make the argument that he doesn't really meet the criteria for any of those drugs because he doesn't have CIS. He only has papillary disease. If he's got CIS and high-grade T1, it's probably a little bit easier to get him that stuff. But yeah, usually you talk now about gemdosi, Activa, Adstiladrin, cystectomy, and then clinical trials for all of your patients who have moved past all that.
Yeah, and I mean, it does seem like there's a lot more convergence than divergence between academic and non-academic. You better believe if I signed somebody up for some Adstiladrin, it got administered and we didn't get pay, Manoj would be giving me a call and asking me what the heck happened there. He wouldn't be very pleased. And we've also got to be strategic. I mean, even just going through the process of having to go through the pharmacy, et cetera, training up personnel, it's a commitment. And while we love to have every clinical trial in every clinical space, it's also not super feasible with our limitations on the clinical research office, et cetera. So BCG unresponsive, let's just say gemdosi, that's available. There's no kind of massive cost implications to the practice.
One thing, if I could say one thing about gemdosi, which I think is important for people to hear. So community docs, the community has typically really underutilized gemdosi. It's not because we don't like it, we don't believe in it, we don't know the data. It's because it is a nuisance to give in the community. So a couple things. There's a Medicare ordinance called USP 800, which basically says that as an independent facility, you're not able to just bring in chemotherapy to your center and just give it. You have to have a certain amount of infrastructure to give. And what's going on with gemdosi is you get the bags. The gemdosi is designed for intravenous use, and then you're basically reconstituting it, and then you're giving it in the bladder, right? And so that's technically not allowed, or that is a barrier in the community. So a lot of groups historically have the discussion has been, well, you need a negative pressure room, you need a hood, you need an oncology trained RN to do all of this stuff. And it's state by state, right? So different states have different kind of regulations and how they look at all this stuff. But one of the big things with gemdosi is it is significantly underutilized in the community because of some of these barriers. And then also you got to buy it. You have to get it compounded, which adds extra cost. You lose a lot of money on it. And so, again, we've kind of worked with, LUGPA, some of our big community urology channels. We've kind of worked to find some solutions. One of the solutions is partner with your local hospital or your local cancer center to do this. So if there are community urologists that are listening, and we get a lot of these inquiries about this, the simple answer is you don't have to do it yourself or kill yourself trying to figure it out. Partner with a local hospital or a local cancer center. They actually like doing it because a lot of them get 340B pricing and they actually can make a lot of money on some of these things. But I drafted a protocol, for example, of how to do it, how to give it, what meds to give, and I gave it to my hospital system, and so all our patients go there to get it. So that's another side note about gemdosi, really underutilized in the community. A lot of groups are now finding ways to give it, but we have been really slow to the party.
Super practical. Totally appreciate it. I get it. Here at UC San Diego, when I started 3 years ago, it wasn't available, and it was a bit of a process because it had to be given to the cancer center, which is 50 yards away from our clinic, and it was a whole workflow things and educating the nurses over there on intravesical instillation. So one, I can appreciate that. I also appreciate the state-by-state nature of it. This is not an original idea that I had, but Yair Lotan would do office biopsies, fulgurations for his kind of chronic low-grade folks in the clinic and then just put in some gemcitabine right there. And I was like, that's brilliant. Just kind of handle it all in one go. And so I can appreciate that. And again, it's not a judgment thing. I think these logistics, maybe some familiarity are noteworthy. And so let's just say that they get gemdosi and they recur. Now you're making a decision on, how does my large urology group practice in Nashville flesh out our portfolio? So let's call it, BCG, unresponsive, gemdosi, refractory, not getting a cystectomy because either you don't think they need it or they're not fit. So what do you have available?
How do you order all this stuff? Yeah, so I've used a lot of Adstiladrin. What's really nice with Adstiladrin is patients almost feel like they're getting a break because of the quarterly dosing, right?
Let me actually back up. Let me back up a second, Tom. So you're sitting there in practice, obviously kind of keeping up with things. How do you make the decision on what I'm going to pursue next? Are you going to the SUO? Are you going to the AUA? Are you, you're talking to your buddies at Vandy? Like, what happens?
Well, so one of the nice things about being really involved in clinical trials is I'm myself, I go to a lot of meetings. I talk to a lot of folks, like I said, I'm kind of fortunate to wear this hat of doing a lot of research. So, I'm pretty involved in a lot of this stuff. So, yeah, so that's part of it is just going to the meetings and talking to folks. But also because I do so much bladder cancer, as you know, you just kind of live it. You just kind of live this world and you have anecdotal experience, which becomes significant after a while. But you're right. The average urologist, I think, who doesn't do a lot of this, it goes back to this notion of how do those people keep up, right? And I think the simple answer is you don't. You refer it out to somebody who does a lot more than you do, and that's probably the easiest way to do it.
So you're living in this world, and it sounds like you have experience at Adstiladrin. Walk us through a little bit, just so you decide, you see the data, you're like, okay, this is compelling. I've looked at the complete response rates, progression-free rates, cystectomy-free rates, and you've decided that, all right, gang, this is the one that I think is the right next step, fastest horse as it stands. Can you walk us through a little bit about the process at your institution to operationalize this?
It's been easier than we thought. We have an oncology RN who I basically send a message to. I talk to the patient about the drug, and she coordinates with our admin about buying it and storing it. Again, one of the big defining things about all of these drugs as they come out, to me, is going to be the logistics, storage and handling, cost, some of the corporate policies about, making groups whole if a patient doesn't show up. In the community, that's going to be the biggest thing. My opinion is that the CR rates, like I said, are all going to be comparable. And you really shouldn't be comparing them, because we talked about certain trials have reinduction, certain trials don't. Certain trials have mandatory 12-month biopsies, certain trials don't. So the CR numbers are fine, but they're definitely not a perfect indicator of how each drug is going to compare against another. So yeah, like I said, it's been pretty straightforward with nadofaragene. We put the order in, and the drug gets ordered, and our oncology nurse administers it. It's, again, quick. The patient stays for a fairly quick amount of time. And again, the big benefit that I've seen is that patients feel like they're getting a break, because they're used to weekly BCGs. They're used to a ton of interventions and treatments. And now you're saying, okay, we'll back down. I've liked that.
Yeah, so just a couple of comments. That's kind of our first one that we had on formulary. We've got some of the newer ones coming through the pipeline, working to get those on formulary. So Adstiladrin is the medication I also have the most familiarity with. Access support, it's good. We kind of learned the hard way, actually. One of the dudes showed up, and they were like, oh, yeah, it's going to be like $20K. And he's like, yeah, well, I'm not doing that. And our institution wanted to do all the pre-auth, et cetera, in-house. And then, shocker, shortly after that experience, we leaned on the access support outfit. So basically you submit a form with the clinicals, and they're like, yep, it's approved. They kind of work with insurance, and it takes it off the plate. And we've got a whole mechanism too where the patient's contacted. The storing and handling wasn't as offensive as I thought it would be. We brought on Gelmito. That was a bit more involved, but we're happy to have it. And we touch base with them. We get a UA usually at least about a week prior with the reflex culture. We don't want to discard the drug. And thankfully, there's a pretty good process in place. Like if you were to have an issue, they had a spasm and they leaked out the drug, God forbid, that's a pretty expensive micturition. So there's some kind of tips and tricks in there, but I have found that the customer support, patient support has been quite good. And honestly, when I first learned about the drug, the every 3-month dosing, I was like, whatever, it's between saving your bladder, not who cares if you're getting 6 or 1. But I would agree. The patients kind of like it. And for our folks that are coming in from, the Central California or Western Nevada, I think some of the access things, like I'm sure for you guys, you mentioned, Southern Kentucky, Northern Alabama, that might be kind of nice. So it sounds like that's your kind of next go-to. And then what comes after that?
Yeah. I mean, it's a discussion. We used a lot of Pembro early on. We were one of the early adopters, early groups of operationalizing in-house Pembro in a big urology clinic. And we've been fortunate now that experience is starting, amongst big urology groups. We've got some survey data that about 20 to 30% of big urology groups are giving Pembro in-house. And we have some resources. There was an AUA update that we wrote about managing side effects. There was a couple courses we gave the AUA. So there's a lot of interest and enthusiasm and I think know-how now on how urologists can give IO therapy. So I don't think that's a huge barrier. But honestly, I think this too, the data just isn't that great. And anecdotally, it just hasn't worked as well. I just haven't been as thrilled about it. And I think probably the role of IO in bladder cancer is going to be in combination therapy in non-muscle invasive bladder cancer. I don't think monotherapy is going to be a home run. But so, Pembro is still an option, especially if patients are really bothered. Their bladders are beaten up. They're, have a lot of irritated voiding symptoms. Pembro is a nice option because it does provide them with, a non-catheter based alternative, although you have to deal with the systemic side effects, which, again, as I mentioned, I think are pretty manageable in the right patient. And then, so then for us, it comes down to a clinical trial. Anktiva is very new and very exciting, but it's still very new. And they're kind of going through with what Adstiladrin went through a year ago, right, with getting their average sales price tabulated, with getting universal coverage, with getting a J code, with getting Medicare pass-through status. So all that stuff will take time. And, Anktiva is certainly something that I think could be the next step, just like Pembro. But probably in our practice, we'd move them towards a clinical trial.
I think it all makes sense. Well, Tom, this has been both enlightening and fascinating just to kind of hear about more of the similarities than any differences that I think we're all kind of facing. And what it highlights to me is it is getting increasingly more exciting and complex at the same time. We're kind of, like I mentioned, from the same vintage where it used to be, you got BCG, then basically got your bladder out. And, that was kind of it when we probably kicked off. And it's really nice to think that there is a lot more opportunity to personalize, to appreciate some of those nuances, to have options really at the end of the day, because we want these tumors to not come back. We don't want them to progress. And ideally, we'd like you to get through the whole thing with your bladder intact. And that's kind of been my big takeaway. More importantly, I'm interested in your takeaway from our conversation.
Yeah, no, I mean, I think it's been really interesting. I agree with you. I think we're all kind of dealing with a lot of the same issues. I think bladder cancer has come a long way. Something as simple as a multidisciplinary tumor board, in community practice 10 years ago, it sounds so silly, but it was probably a rare practice that had that. You'd have tumor boards, but you would very rarely have GU-based tumor boards or even bladder cancer-specific tumor boards. Now in the community, we've built a lot of those bridges, and we're doing a lot of that stuff. And so the care of bladder cancer care has really, really improved in the community. And a lot of these new therapies have helped, right? Because like you said, there's been this kind of marriage between industry, the clinicians, and patients to really try to move things forward. So yeah, I mean, it's really interesting, really exciting. There's a lot of things going on. It's just going to continue to get more complicated, more involved. There's going to be more things on the menu every year, and we're going to have to find ways to sort it all out. But I agree. I think in this space, the important thing is, how many patients can we spare from really life-altering surgery? And if they need it, they need it. And I think that it's important to be able to do it well. But I think it's a bigger win if you're able to get them through the process without having a cystectomy, or maybe just delaying it quite some time, so that patients can have more time, more quality of life, with their bladders intact. So that's the ultimate goal. I think that's the real exciting part of all of this new stuff, is now we've got all these options where 5 years ago we had none.
All right, Tom. Well, it's been a pleasure. Thank you for your time, and hopefully the Titans turn around and see what we get.
All right, man. Thanks.
Thank you so much for listening. If you haven't already, make sure to follow, rate the podcast 5 stars, and share with a friend.
If you have any questions or comments, you can direct message us at _BackTable Uro on Instagram, X, or LinkedIn.
BackTable is hosted by Aditya Bagrodia
and Jose Silva.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening, and see you next week.